Yeah, and we're going to get into that. That's going to be a highlight of this podcast is what you are doing to try to get the label changed. But before that, the last time you were on here, we were talking about these steroidal antidepressants. I think one was Zurzuvae, right? And there's another one, Zulresso, I think. And this goes back to the fear provocation, because if you can manufacture this disease and you manufacture fear, then you have a treatment to sell to somebody. But the risks of that treatment were so significant, meaning like unable to drive a car. And how do you take care of a baby when you're under that type of altered state of consciousness, like, and it has that type of consequences, let alone all the adverse effects of all other antidepressants, and then passing it through the breast milk, right? So we now have to get into talking about informed consent, right? We know that in most hospital centers, it's something you sign really quickly before you even meet with the doctor. It's kind of almost attesting to the fact that you were provided informed consent. But the standard's much higher than that ethically for you as a physician and for me as a psychologist as well. When you do come across a pregnant woman or woman who is certainly in the early stages of pregnancy or wants to become pregnant, and they're on an SSRI or they desire to be on an SSRI or other psychiatric drugs, how do you communicate to them the risks and the benefits to start? And then we'll get to alternatives.
Yeah, I think this is absolutely crucial, that conversation that we have to have. And I think to give my colleagues to just explain it, I do think that I try to look on the good side, Roger, of humanity and my colleagues. I do think the docs I work with want to do their best by their patients. But I think part of the problem that a lot of providers are up against these days is the time limitations. And there's a limited amount of time in an office visit, certainly in an OB office visit, a prenatal visit, to try to go over these things. And so, honestly, the quickest way to get through a visit when a patient's on a medication is to say something like, it's safe and effective and doesn't, you can take it in pregnancy, and then that would move along to the next patient. And so this is a problem in our whole system, not just for taking care of pregnant women, but in general. That's why it's hard to do the informed consent, because it really takes time. I'm fortunate as a specialist that I have more time with patients, so I'm able to actually spend the time with them and go over these things, and I'll go over that in a sec. But I just wanted to give a little anecdote. I lectured on this many years back at Tufts, speaking with the department and the fellows. And one of the fellows at the time, who didn't have much of a filter, I finished my lecture, and she said something to the effect of, "Oh my God, if I actually believe what you're saying, I actually put that in practice, I could never get through my day." Because it takes a significant amount of time to be able to explain these things to patients and be able to really go over it with them. But I think it's crucial. So I guess one thing that I'm saying is I think a lot of the informed consent conversations not going on, not because doctors and OB providers don't want to do that, but because simply the time pressures in practice nowadays. What I usually do with my patients when I see them in the office and we have this discussion is I first try to figure out where they're at, what their mental health history is, how they're currently doing, et cetera. And then I try to make sure from the gate that they understand that it's not conversation is not about pill shaming and making them feel bad and that sort of thing. I try to support patients. I do tell them that we don't ignore health issues, whether it's hypertension or epilepsy or depression. We don't ignore mental health issues in women just because they're pregnant. So they'll understand that we're not going to ignore what they're going through or what they're talking about. And I also try to broaden the discussion to explain that this isn't just about mental health medications, but more broadly, it's counseling that can apply to medication use in pregnancy in general. And what that counseling is, so for example, if you've got a patient with hypertension, we don't tell the woman, "Oh, you're pregnant now, so you can't be on a blood pressure medication. You just have to have out of control blood pressure and stroke." We don't tell them that. We'll control that. But what we try to do with blood pressure in pregnancy is we try to use the lowest doses, the fewest number of medications, the shortest period of time, but while still taking proper care of the mother. So that becomes then the rule of thumb. You want to use the fewest medications, the lowest doses, the shortest period of time while taking proper care of the mother, including not taking any medication at all. And then I try to work from that general framework, which would apply to any medications, to their specifics with the drug that they're on. And then review or go over with them the various risks. And then the benefit I'll get into in a sec, but the risks I typically go over with them are the ones that I've laid out earlier, which is risk of miscarriage, risk of birth defects, risks of preterm birth, risks of low birth weight, risks of preeclampsia, a disease called preeclampsia, postpartum hemorrhage, and then newborn behavioral syndrome, also called poor neonatal adaptation, and then long-term effects, long-term fetal effects, including things like neurobehavioral problems, as well as gut or gastrointestinal problems, which have been shown to be more common or more frequent. So we go over those risks. In terms of benefit, the benefit discussion with the patient for these things can become challenging because the evidence, the medical evidence, which I know we've gone over on this show numerous times, the research evidence isn't great for showing a clinically significant benefit. Many of those studies were just done over short time periods. Many of them did not show any benefit for mental health. The long-term data trying to show that it has long-term benefit is basically absent. The STAR-D trial that was originally used to try to show that's been shown to have many problems, and there's a lot of controversy about that, the way the data was monkeyed around with. So there's not particular benefit in that sense, but for a given patient or an individual patient, one of the benefits to them can be the avoidance of withdrawal. And that is an interesting area because about half of pregnant women, when they come in, about half of pregnant women coming into pregnancy will stop their antidepressant. And it's an interesting phenomenon because of that half that stop, many of them appear to be able to do okay. That's typically not what's recommended. Now the movement is towards tapering, hyperbolic tapering, et cetera. You can discuss this better than I can. But many pregnant women, when they find out they're pregnant, will stop. It's roughly half. And many of them will do okay. Some of them don't, and some of them do very poorly. And so for a given woman during her pregnancy, where she's at, the dose that she's on, her mental health history, that benefit for her may be in continuing something that she'll have significant trouble in coming off of. And so that's a discussion that I have with them about what that would be like, tapering, staying on, how she wants to manage that. And so that becomes the benefit piece to it. So I guess to summarize, not real evidence of benefit for these medications, at least from the studies that are out there, but benefit in the sense of avoiding withdrawal for the mom. And then alternatives, talking about good approaches to mental health in terms of some of the issues you were talking about earlier. You can do psychotherapy, you can do exercise, nutrition, proper nutrition, importance of sleep, which as we study it more, realizing it's more and more crucial, trying to optimize these things, your relationships, what you're doing, the meaningfulness of your work, sun exposure. There's a lot of other options or a lot of options to really help with mental health in terms of what those alternatives are. And so this, as you can imagine, though, from just hearing me go over it now, is a lengthy discussion. Going through those risks for patients in terms of what is preeclampsia, why do the SSRIs increase preeclampsia, what is postpartum hemorrhage, why do they increase postpartum hemorrhage, poor neonatal adaptation, what does that mean? That can mean the baby's being restless, agitated after birth, higher rates of going to the NICU. This is a long conversation with patients, but it's one that's really important. And then at the end of that, I tell the patients, what you decide, I'm going to support you on, because they're my patient. They're a mom typically in my community, the community that I grew up in, that I live in. I'm going to support her, and I'm going to be continuing to see her through that pregnancy for ultrasounds, figuring out how the baby's growing, how things are looking. And I want her to know that I'm in her corner. I'm supporting her for the remainder of the pregnancy, and that we're going to kind of try to work through this together.
Doc, my head almost blew up when you told the story about the woman who states that she just doesn't have enough time to provide anybody informed consent, and it's just so much easier just to tell them it's safe and effective. Um, so, there's certain things I learned when I was 4 years old. And I think I taught my kids that. And I think we have this way of overcomplicating a lot of things. And I've heard this so many times from doctors who are able to justify their inability to be able to provide informed consent by the time restrictions that they have. And the thing here is the golden rule. I mean, I learned this when I was pretty young. It's pretty much like you treat others the way you want to be treated. And in other things that was like really important that was taught to me, and I try to teach it to my kids, is don't lie. Don't mislead people, right? Like, you do those two things in life, you're probably going to be trusted. You're going to have some really good relationships. You're going to live a life of honor and integrity. So I was just looking at the time as you were kind of going over informed consent, right? And what's fascinating is you keep talking about how long that is. It was less than 10 minutes. Like this is like somehow drilled into the minds of the modern medical professional that, my God, you can't have 10 minutes to say that if you take this drug, it could have potential long-term consequences on your fetus, on your child. You can lose your child by taking this drug. But my God forbid, we don't have 10 minutes. And the other thing is, I'm pretty sure it's 2025 and we have like technology. Like there's podcasts, or you can actually record informed consent onto something and send it to them on their phone. So even if you don't have that, you can like provide them informed consent. They can listen to it. They can listen to a podcast. And this is how dumb I think we've all become. Like we're just supposed to accept and walk away. Like, oh, damn, not enough time. Safe and effective. Hey, it's on the vaccine schedule. It's got to be safe, right? Like, yeah. When has our government or any government in world history ever failed their citizens? So we just can't be that dumb anymore. And then I want to add in this other piece. This is from Dr. Andrew Kaufman, who I've recently found. I find him fascinating. I think he's really smart. He's actually a psychiatrist, and he posted this today or yesterday. The U.S. economy is heavily dependent on the medical industry. If we truly divested from it, it would trigger a massive economic shift. Just look at how many new industries were created during COVID. Now imagine that level of expansion and transformation playing out over decades. So one of the things that is happening here, and this is hospital administrators, bean counters, who say you have to see this many patients in this amount of time, is they have the power apparently, but they really don't. We don't need hospital administrators. We don't need bean counters, but we need physicians. You have all the power. Every physician that's listening to this, you have all the power. They can't survive without you. Fuck them, right? This is about informed consent, but this is also about your personal integrity, right? And here's the thing is, when you go to any ethics seminar or take any ethics class, ethics supersedes law. It supersedes law. You can violate the law, get yourself a lawyer up if it interferes with your ethics. If it breaks your ethical code, like if it interferes with your ethical code, then you have the right and responsibility then to fight the law. And that's part of the problem that exists is there's this fear and dependency that physicians have. It's such a system that's created because they're in tons of debt. They're beholden to the system and they just follow it, right? And this is corporate medicine, where now they just follow these protocols and we've lost the independent physician.